Hi, everyone. I'm Vidya. I'm a volunteer with Fertility Matters, and we're so fortunate to be here today with Dr. Ari Baratz, who is an RE at Create Fertility. Thank you so much for joining us, Dr. Baratz.
Thank you, Vidya, for having me. And thank you for all of our FMC and community and all Canadians that are interested in learning more about fertility care, those that follow us on various social media outlets, and those that support us and are asking all these great questions.
Wonderful. So as everyone knows, you're joining us during Canadian Infertility Awareness Week. All week long, we're bringing you content featuring amazing professionals in the field who help us to grow our families and help us to balance the medicine with the mental health aspects as well. And this CIAW, our theme is Find Your Joy. And one way to do that is to explore patient-centered fertility care, which is what we're talking to Dr. Baratz about. So this is something that we don't talk enough about from the patient perspective. I've been there. I get it. We're used to kind of being directed one way or another. We don't really understand the medicine or the science behind it. So we don't know how to advocate for ourselves or even what's possible. So that's why we're here today with Dr. Baratz, who can walk us through what patient-centered fertility care can look like with practical examples or practical applications within the context of fertility treatments. So that being said, why don't we just start, Dr. Baratz, with, can you define what you mean by patient-centered fertility care?
Well, I can define what I mean by it. I'm not sure if I can define what the world means by it, but I will thank you for that introduction. And I will share how, at least in my world, in my professional world, this evolved. So it goes way back when I was in medical school in London, Ontario, at the University of Western Ontario.
Yes,
Yes,
my alma mater as well.
I was, go Mustangs. I was first exposed in general medicine to the concept of patient-centered care. The fertility piece I added on later as I started practicing in that space. And so I suspect if you asked any of my classmates from back in the late 90s, early 2000s, what is patient-centered care, they'd probably say something to the effect of looking at patients as a whole person, understanding their disease process with quotes around it, because obviously the term disease means different things in different circumstances, but then layering onto that the unique illness experience. So how they are interpreting their broken hand or their chest pain or their fertility or infertility. And then that creates the whole patient or person. And then that is also contained inside of a context, whether that's family or the place you live or the culture you subscribe to. That's patient-centered care. Patient-centered fertility care is when you specifically apply it to our space in terms of fertility treatments, diagnostics, therapeutics, and the sequelae that come from that. So that's sort of high level. And we can certainly get into some practical applications. But what I would like to say, though, is the other piece where I think patient-centered care comes into place, it's not just the overarching framework, but when I think of like the forced pauses that we have with our patients, their families, those are these little patient-centered opportunities, right? How are you feeling about this? How do you see this heading? Where are we going? What are your thoughts on this? What are your feelings, your ideas? How is this impacting your function as the patient, as the one experiences? And what are your expectations? Because if we're just going along a clinical train and we're not taking any of these forced pauses, these stops, and actually getting off the train every once in a while and understanding how is this affecting your specific patient, it's difficult to be successful. Because if success is just being measured in terms of live birth rate, well, we're going to dissatisfy a lot of people because we know that many look at success in different ways. So that's a little bit on my take on patient-centered care and patient-centered fertility care.
I love that so much because like I can think back to my own fertility journey and recognize parts of it where I felt like, okay, how are we jumping to this when I don't understand what's going on here? And that was a moment that should have been a forced pause. So it's interesting because you're coming from it from like the doctor perspective, and we're talking to the patient community now. So this is an opportunity to kind of give advice to the patient community to say, like, here's how you can achieve this if it's not something that you might be getting at the moment, right?
Mhm. Well, patients, it takes on many forms. And I know that we've discussed this. We should really call this talk Patient-Centered Fertility Care 2.0 or 1.1, because we did have this talk before when we just introduced the diagram. I think we put up a few diagrams that describe this. And so patients can look at that earlier talk. But as I continue to think about this concept, and as fertility medicine and reproductive care evolves, there always becomes these new opportunities to infuse patient-centeredness. And I think it would be a great opportunity to talk about some of the applications or ways that we actually see this. Or did you have
Mm.
any other specific questions that you wanted to ask me?
No, let's jump into that. So I think we had talked before about talking about natural cycle applications in the
Yeah.
context of fertility treatments. Do you want to
Well,
explore that a little bit?
sure. I think that's great. Well, first of all, back to we have an acronym that we use when we talk about patient unique experience. It's called FIFE, F-I-F-E, feelings, ideas, fears, and expectation. FIFE. And very often, when a patient is worried about care, the obvious worry is that it's not going to work. But there might be other sub worries, like it's going to be painful, it's going to be expensive, it's going to take more or less time, it will be artificial or it'll be natural. And so, one of the probing exercises, and obviously it has to be all wrapped in success. But one of the probing exercises I do with patients is when they describe resistance to something, I always ask why. I go, walk me through this. Like, what are the fears? And so where natural cycle comes in is very often when we talk about fertility treatments and advanced care, it's wrapped in artificialness and it's wrapped in sterility and it's wrapped in the lab. But there are ways of trying to make it a little bit more natural. And in fact, there are studies coming out, and you'll see more of them in the next year or so, that show that some of these natural applications may even be more successful. And so one of the examples I want to share with you is the whole idea of natural cycle embryo transfer. So when someone's going through IVF therapy, they will learn that at some point, if they do build embryos in the lab, there will be some way of putting the embryos back inside of them. And the field has moved away from fresh embryo transfer. So that means in the cycle where we're actually producing the embryos, we're tending to move away from putting the embryo back 3 to 5 days later. We are now freezing more embryos, cryopreserving them, and waiting until subsequent cycles to transfer them. And there are many reasons why we do that. We do that, A, because patients may not be ready to be pregnant at that point. They may feel unwell after their cycle. There may be testing that we want to do on the embryos, or they may be trying to coordinate that with another party, like a surrogate. So there's many, many reasons why we freeze. And freezing is very artificial. There's nothing natural about it, except when you see ice outside in Manitoba, I guess, in April, but which might not be very natural either. But so the freezing part is artificial, but that is a patient-centered approach because it allows patients to pursue all these other applications. But going a little bit more, drilling a little more specifically, very often the putback protocol or the transfer protocol is very artificial, involves a lot of medications and drugs. And there's a large group of women that are having natural cycles or cycles that can be induced through ovulation induction. And we can use those cycles to create a more natural way of transferring. So we call it natural cycle frozen embryo transfer. And even though in some ways it might be more cumbersome and require more visits to the clinic sometimes, for many people, their fear is they're being exposed to too many drugs. They don't like the idea of being on medications. There may be some cost savings. And so we explore that with them. And interestingly, there are some data sets, and there will be some randomized control trials coming out soon that I think will support this, that a natural cycle frozen embryo transfer may in fact not just be equivalent to our traditional hormone-based transfers, but may be superior.
Wow.
So that's interesting because it's coming from a patient-centered angle, right? Like, I don't want to be on drugs, doctor. I want something that's a little bit more natural in this space of unnatural things. And now we actually might even have data that says it's better. And so we could have a whole talk about the corpus luteum and what it does when you ovulate and its benefits. But I use it more as an example to say this is another way of doing something that might be more comfortable, might be more patient-centered for some people. It might not be for others.
That's super interesting. It's really interesting to hear that the results may in fact be superior. I'm really looking forward to digging into that a little bit more.
Right.
And for those watching, I'm 90% sure from my celebrity gossip memory, that Kim Kardashian did a natural cycle transfer.
Kim Kardashian. Well, I don't know if Kourtney Kardashian did, because she described a different
Oh,
experience.
she did describe a very different experience.
So, but I think that those. So just to not confuse our audience, I mean, this is still part of the IVF process. So there's still many unnatural parts, but at least we are disarticulating the process. We're applying some naturalness to this, and not only make it feel better, it actually might even work better. But going along those lines, the natural cycle in women that are cycling, or women, when we say natural cycle, we mean those that are having regular menstrual cycles, or cycles that are conducive to using low-level fertility drugs to induce ovulation. Look, we have patients that have their natural cycles tracked at our clinic, so that we can give them feedback on when to be intimate or when to inseminate. We use the natural cycle all the time to prepare for subsequent cycles. So, like sometimes just tracking a cycle may allow that element of patient-centeredness, might give people that hope that the natural cycle still may provide for them and be successful.
Great. So what are the options for patients who feel like this is something that they want more of in their treatment with the clinic that they're with, or with the doctor that they're with, but they're not really getting it in a manner that's acceptable to them?
Right. Well, I mean, we gave one example, right? I mean, patient-centeredness is typically peppered, across the patient experience, and it may be part of the intake. It might be part of the diagnostics. It may be part of their treatments. Giving another example, you may have patients that are in early phases of their journey, and for a whole myriad of reasons, they've said, I don't feel like doing a fallopian tube test. It's a painful test. I don't want to do it. I mean, obviously our textbooks and our protocols mandate that fallopian tube tests are a intrinsic part of evaluation, but you don't have to rush to it, as long as a patient has informed consent and understands where the gaps in knowledge are. If we don't do a tube test, there's nothing wrong with staggering the evaluation. I think that's so. From the intake, being open with your providers and saying, I appreciate, this is from the patient's perspective, I appreciate that to have a fulsome view of my case, assuming it's, whether it's a case of a single person or a hetero couple or LGBT space, we know that you always have to satisfy three components. We need some egg source, we need some sperm source, and we need to know about the anatomic situation. We don't have to evaluate them all at the same time. I mean, we like to, but we can do this in a stepwise fashion. Some people might be more interested in one area of their care or another. So that's a patient or client coming to their provider and saying, can you please do this for me in this sequence? So that's from the intake. I think always asking and probing and saying, are there other ways of doing this, or is this the only way we can do this? And the answer might be yes or no, right? So patient-centeredness also comes with open-mindedness, realizing that not everything can be done as you like it, but there may be opportunities for that. Very often there can be areas of just lack of knowledge. Like sometimes people feel that if they don't transfer their embryos the next month when they make them, the embryos will go bad or they will go stale. And so I very often had this conversation with patients where I said, look, if you're working on a project right now and you want to delay your embryo transfer by 3 months or 6 months, or you're involved in something else, that's okay. Like that's not going to change your prognosis radically. And that, again, that's an element of patient-centeredness, because it's allowing people to address their whole person. If people are sacrificing every aspect of their lives to conceive and it works, great. But if it doesn't, they may have sacrificed too much in other areas. So I'm not prescribing one path or another. I'm saying that for some people, serial transfers or serial treatment cycles month after month is the way to go. And for some people, the way to go is to have these gaps, and they need to be reassured that those gaps do not necessarily ruin their overall cumulative pregnancy rate or their chances of being successful. So those are just some examples of how people can be more active and more vocal in their care. Sorry, excuse me.
Love that. That's okay. Do you have any other advice for patients advocating for themselves?
Well, again, it depends on the jurisdiction. It depends on the clinic you're in. Another example, I think when we were brainstorming about the session, I was giving you some ideas of just some of my thoughts about new and emerging trends. So sometimes we have the other spectrum where people don't want to move slowly, but they want to move really quickly.
Yeah.
And so quickly that they feel that if they don't move quick enough, that they're not being heard. Sometimes we have patients from far away. Even if they're in Canada, they might be living far away, or they're far away in their schedule, like meaning they've carved out time and they want things to happen really quickly. So this natural cycle I talked about may not be as simple as we always thought it. So there are new forms of IVF that we're doing, which allow couples, women, men, to do IVF cycles in quick succession. So I think we were talking about double stimulation as the other end of it, like meaning people that are doing traditional IVF in a sort of non-traditional way. So double stimulation, the reason that's interesting.
What is double stimulation?
I know,
what is
it's
that?
great. So what we do there is typically for people with lower egg reserve or low responders, instead of doing an IVF cycle and then making them wait 2 or 3 months or 4 months until they do the next one, which has a whole bunch of other non-patient centered issues associated with it, wait times, dropout, frustration. Because our knowledge of the natural cycle has evolved and we realize that there's actually multiple waves of follicles that develop, not just that simple one follicle wave each month, we're now bringing patients back, not like months later, but 5 days later after their egg retrieval and starting another IVF cycle. And so we've given talks on double stimulation. I think some of our other experts on Fertility Matters, talking about fertility have done that.
I need to go look those up. That's fascinating.
But it's sort of been long used in our oncofertility population, like our cancer patients that are going through fertility treatments for preservation. But we're now using it more and more for our poor responders or lower responders. We're also using it for just men and women that want to do rapid sequence IVF. And we're seeing that the success rates, it may confer more benefit, but it also just allows their schedule to move more quickly too. So another example of adjusting dogma to be more patient-centered.
I feel like I could talk to you about this all day, but I know that neither of us have that kind of time. Are
Wow.
there any other examples that you want to give, or any other, I guess, tips you want to share before we close off?
Well, another one is that, like, very, very often fertility clinics are very focused on a certain bottom line, live birth rate, pregnancy rates. And look, that really is in many ways the currency of a clinic. That's how you tell if a clinic is first tier, second tier, third tier. And in some countries like the US, they report very widely their success rates. In Canada, we report, but in more of an anonymous way. But for a patient, that may not be their only bottom line. For a patient, there is the concept of being able to try, being able to have their opportunity. And that's another manifestation of patient-centeredness. So what I'm getting at is that even if the clinical opinion is IVF confers the best success rate, sometimes patients do need to consider other technologies, perhaps IUI, or even backing off to natural conception, not because it has the highest pregnancy rate, but just because it's an opportunity, it's a better fit for them. And sometimes even in the IVF space, when we start to quote lower prognosis, sometimes patients just need that chance. So acknowledging that pregnancy rate may not be the only thing that some patients are interested in, acknowledging that people want to have that opportunity, that's another version of patient-centeredness. It doesn't work for every clinic. I mean, it doesn't work for every place because there are certain resources that need to be considered, but that doesn't mean that patients can't search that out. And there are many providers that, as long as there's been full disclosure in terms of what the success will look like, are very happy to hear you and help you. And as long as people know what's available, and then they've selected from that list of availabilities, that's different than being prescribed something and saying, no, you can't do this, or your only option is this. So people want to have that conversation. It takes time. It takes time on the patient side to listen, to ask those questions, courage. It takes time on the provider side. to go through that exercise. It's hard work, and these are very sensitive issues. So that's another piece of patient-centeredness, is not being afraid to explore the feelings, ideas, impact on function, and expectations. I mean, we know very well from the literature that a main reason why patients drop out is just sheer frustration. And maybe if they could be heard, maybe if there were more counseling services available, not just from the counselors, but from the doctors too, or the nurses, more patients would at least have insight into what's going on, and then and then at least be more satisfied if they're walking away, as opposed to being, just plugging away without thinking and taking those pauses.
I think that, like, from speaking from experience, I remember early in my fertility journey, I didn't have the courage or maybe the confidence to ask for what I wanted, or to even ask the questions to figure out what it is that I wanted. And I think by the end, my frustration presented itself as just saying what I wanted. And I was able to get it, like, not like nobody handed me a baby, obviously, but I was able to kind of change the way I received care and who I was receiving care from, so that it was a more, I don't want to say enjoyable experience. No one loves going through fertility treatments.
Just less painful.
Yeah. There's so much
Right.
that's like painful and difficult about this process, and the easier we can make it for ourselves, the better we can think about it when we look back on it.
Right. Like I don't want to mince words here. I mean, there are certain guidelines that we have to follow. I mean, if a patient said to me, "Well, I really want to have 4 embryos transferred," so, I mean, that's obviously a different conversation than if someone says they want to have a double transfer, or they have issues with a single transfer. So it might be that, like, because we know that single embryo transfer is really the standard of care. It's what we subscribe to. Government, at least in Ontario where I work, government plans mandate it for certain age groups. So we can't patient-centered our way out of that one. I mean, like, there's certain things you have to respect, but perhaps the gap is just addressing that fife again, those feelings, ideas, function, expectation. Like, perhaps patients think that if they don't have a double embryo transfer, they're less likely to get pregnant, or it won't work, or the embryos won't survive in the freezer. And those are all myths, right? We know that very well, that if you do serial single embryo transfer, you'll probably do as well, if not better, than just throwing in 2 or 3 embryos at once. But if someone's working off of some preconceived notion, if there's a gap in knowledge, you won't be successful. So in getting the buy-in that we need from patients to accept a certain path, or understand why that path is being offered. So I don't want to make it seem easy that patients can convince their providers, or providers can convince their do it this way. Really, what I'm getting at is it's a respect of those concepts. It's at times a negotiation. It's a lot of listening.
Or collaboration.
It's collaboration. It's negotiation. Well, it's both, right? Because sometimes you have to agree that you might go down one path, but all of these things are via communication, right? They're not implied. They're not dictated. Some of them are mandated because of the government, but many of them are conversations, exploring. Sometimes patients will bring ideas to me that I just hadn't thought of, and I just having that conversation. I'll have patients send me articles that they want to discuss. So again, I'm not trying to say it's easy. I mean, we only have so many hours in a day, but that type of advocacy from patients to their providers can be helpful. And I don't think it's harmful. Like, at the end of the day, we have a principle in medicine, which is do no harm. No one is going to knowingly harm somebody. That's one of the main principles. We will never compromise there. But the way we get to doing good may take a few more steps in a patient-centered practice.
Well, I found that incredibly informative. I'm assuming that everyone watching will also think that this is a really great talk. This is probably one of my favorites. So congratulations. Is there anything else you want to say as parting words?
Yeah. Well, what I do want to say is that patient-centered fertility care is something that, even if we do it subconsciously, is something that I believe is part of the Canadian medical fabric. A lot of the articles and original works were designed by Canadian physicians across various fields of medicine. So I don't want the term to seem as if fertility medicine or gynecology has ownership or proprietary ownership over the concept. And it's a concept that people can take to other areas of their healthcare. I'm sure there's patient-centered dental care and patient-centered physio care. But so I guess searching for providers that will satisfy that, because at the end of the day, if you are successful, that's amazing. That will make everyone feel better. But what if you're not successful? And what if there are challenges? Will you feel satisfied? Will you have the avenues and the paths and the laneways to get that information? And so that's why people need to search that out if it's important to them. For some people, that's just not a priority, but it's something to consider. I think your dog agrees. I think your dog agrees.
Yeah, totally. He's very excited by either what you said or the package that's being delivered right now. Okay, well, thank you so much for taking the time with us today, Dr. Baratz. I hope you can hear me over him.
My pleasure.
For everyone watching, please visit the Fertility Matters website. There's tons of resources and lots of information being posted all week long. And if you need additional support or have any questions, please just reach out through the Facebook page, and we'll put you in touch with the right resources. So thank you so much.
Thanks, Vidya. Be well. Bye-bye.
You too.